you. Right. Um, so I think that we have already talked a little bit about the how to use the subliminal laser. I just want to show a few examples as well, and it's always helpful to look at different things. And I think that is something that we have showed before in in diabetic macular edema, and this case has been published at almost 15 years ago now, and you can see that it worked quite well from that point of view. And Ken has already covered how close can we go, and this is another case that we have showed it before, and you can actually go very close. But again, just be careful when you first start it. And once you are comfortable to do it, then it's actually not a big deal that you can get to the very close to the lesion. You can also do it in vein occlusion. Again, to be fair, that vein occlusion is not always work. So I think that in some cases that you can be a supplement to your anti-VEGF, or in this case that is such a small branch vein occlusion, and we could have leave them alone. But at the same time that we decided to do some laser, and actually also it worked very well. And we already talked about central serous before. And there is a lot of discussion about how long should we wait before we treat. And at the moment, that because I'm quite comfortable treating CSR, I don't wait at all. I offer the laser on the first visit when the patient come in. And obviously, some patient might not want to have laser right away, which is obviously acceptable from that point of view. But then you really don't need to wait, before you treat, once you're actually comfortable with your treatment. As you can see, this case is a very close lesion, and you can actually treat it very well. And there's also other cases that you'd be slightly more chronic cases. This case has got a bit fibrin in it, and actually, again, you kind of work very quickly. And this is even closer to the fovea, and again, you resolve very quickly. You can see some chronic cases. This patient actually had previous PDT already, but you can still see that it can respond reasonably well from that perspective. So sorry that this slide haven't updated. So I think that in 2020, diabetic macular edema, vein occlusion, CSC, we are quite comfortable. There's multiple publication on that, and a lot of people have done a lot of work on it, and so on. The only thing is that there is some controversy. Consider that whether that we should treat CSC with PDT first or with subliminal laser first. There is one controlled trial was published in Europe, and comparing the two, and it showed that PDT seemed to be better. However, that it was a bit of a difficult study from my perspective. Is that although that Oxford is one of the sites, but I'm not involved in the study, and in fact that one of the reasons is that most of the doctor who are involved in that study haven't really done some micropulse laser before, and when you're looking at their result, and now that we're realizing that they are significantly undertreating on the micropulse group. So because they're undertreating, so they are slightly less good results. And similarly, there's some other publication have now come out comparing the two techniques, and they are very comparable. And from my perspective, is because that subliminal laser is easier to do, lower risk to the patient, and also lower cost to the patient. Therefore, that I tend to use subliminal first. However, that there is cases that I failed the subliminal laser and then actually work with PDT very well. And again, we still don't understand why. And similarly, that I have patient that had PDT already, even that one patient has free PDT, and then get referred to me, and then the micropulse laser work very well. So again, I don't have a good answer for the so-called outlier that why one technique is better than the other, but I would argue that probably 80% or more that both techniques actually work equally well. And so it's depending on your practice. And certainly for me, that doing PDT is slightly more complicated, taking longer. And so therefore that my first line would be micropulse or subliminal laser. So I also want to talk a few things about other option that we talk about, which have been published. So one thing is about proliferative diabetic retinopathy. That was something that been published before, and that actually raised the question about which layer of cell that you need to kill. I think that I saw that there was one of the question on that. So for proliferative diabetic retinopathy, majority of the VEGF actually is producing by the retina, and not so much by the outer inner retina, as in the ganglion cell, but mostly actually are producing by the photoreceptor, the outer retina. And so therefore, that by killing the outer retinal cell or the photoreceptor cell is enough for proliferative diabetic retinopathy, and there's multiple animal experiments to confirm that. However, that the difference is that in the subliminal, you don't kill any cell. So there's no reason that subliminal laser would work for proliferative diabetic retinopathy, despite Jeff Nitro had published that 12 years ago. And as you imagine that after 12 years that there's no second publication, and you realize that it probably doesn't work. And indeed that we have tried and it doesn't work at all. So I would be concerned that if you want to use subliminal laser or micropulse laser for proliferative diabetic retinopathy. And another publication of macro edema, and not micro, but macro, and they again published it a while ago. And we have tried it, it worked. And again, there is no second publication, but partly because that it's not really that common and it's not, really not providing more information than the Italian group have produced. So therefore, that it seems to work quite well from that perspective. Similarly, that people have considered that if you got a wet AMD patient that it doesn't seem to responding anymore, and then if you do laser, whether you can actually revitalize the RPE cell. And then again, Jeff Nitro's group had published that about 5 years ago. Again, there's a bit of a controversy on that area, partly because of the fact that we have some patient that we switched to different anti-VEGF drug and it suddenly seem to work. But whether that is because of you switching or whether that is something called a return to norm, that basically that if you treat a bad case, majority of them do actually get better. So there is multiple publications show that you don't need to change your anti-VEGF, but just keep treating and then you will get better after all. And indeed that it's difficult to know, but again, it's something that no one has done a big study on it. And we did try it, and then it seems to work. But again, I don't know whether that it worked purely because that we have revitalized the RPE cell, or just so happened that it worked purely because that now that we are retreating the patient again with anti-VEGF, and it seems to be better. But I think that there's very little harm, and it's probably worth consider trying if you are stuck in a patient no longer seem to responding to anti-VEGF. So what else have been might be possible? And again, Ken already mentioned about don't confuse about CC and PCV, and certainly that we have some evidence that actually work on PCV, but again, you'll probably need anti-VEGF in combination as well, and certainly that just the polar part it seems to able to work. However, that the network, the BVM part doesn't seem to work, and partly because that part is probably more a new vessel formation. You probably need anti-VEGF for that. But if you got some of the earlier polyps, it was just really the polyps, and again with the laser that seems to work. And we certainly that a lot of people in the Asia Pacific area using a conventional laser for some of those anyway, and you probably think that is okay, that's fine. But at the same time, that if you want, you can certainly try with some subliminal laser, therefore that you don't cause any scarring. We are still working on the drusen study, and we were just about to start the study, but with the COVID-19, unfortunately, that we were stopped. And so again, we need to wait until sometime later on in the year that we can actually start our royal-free drusen laser trial. And indeed, that drusen removal have been shown that in several group now in small case series, and I think there's some case series coming from China as well. And it actually does show that you can remove drusen. So we're going to do a sham control trial in London, but it's currently stopped, but pure because of the COVID. and then we're going to restart it hopefully in September, October time. So there's also the same group suggested that you might work for RP, Stargardt, and geographic atrophy. And honestly, I don't think that's true. And I think that it's a bit of a shame. Sometimes the people presenting and publishing data which is not necessarily collaborated. And again, people haven't really able to reproducing the results from the same group. So I wouldn't think that you necessarily want to try it unless that you want to do a proper control trial. So in summary, that I think that it's very clear that in DME and CSC patient that it work, and in BRVO and macro aneurysm it seems to work, and possibly work in PCV and drusen, and I don't think that they work in PDR, and then all the other things it probably doesn't work. But I think that if you want to really work on those areas, I would suggest you do a proper control trial.